clinical perspective, which is women's cardiovascular health. And I'm going to talk about female-specific factors that enhance women's cardiovascular risk across the lifespan. Let's see here. Change. Here we go. These are my disclosures. They're not really related to this talk. So first, to set the stage, and this may be familiar to many in the audience, but sex and gender are not interchangeable terms. They actually mean different things. So when we talk about sex differences, we're talking about differences related to biology, from sex chromosomes, sex hormones, gene expression, anatomy. Where gender is more of a social cultural term. It's about identity. It's about enacted roles and behaviors. It's not binary, and it can be on a spectrum. And so health is determined both by biology and the expression of gender. So both sex and gender influence observed differences in women's cardiovascular health. Again, from biological differences, but also maybe how which is due to sex differences, but also gender differences, and how healthcare systems may have different biases and may not be listening to women when they're telling them something is wrong. So these are data from the United States that you may have seen, looking at cardiovascular disease mortality. And in the 70s and 80s, mortality was moving down in men. The first statin was approved in 1987, and there was much more attention to men's cardiovascular health. Where women, were not getting statins, they were getting hormone therapy, their cardiovascular risk was just ignored, and cardiovascular mortality was on the rise in women with this big gap until around the year 2000, when there was the release of the first women-specific prevention guidelines and initiatives like Go Red for Women from the American Heart Association. And after that, there was a dramatic decline in cardiovascular mortality in women and continued decline in men. And this is why I love being a preventive cardiologist, because there's a lot you can do. We think about 90% of cardiovascular disease is due to preventable and modifiable risk factors. But, we all need to be alarmed at what's happening here on this right-hand side of the curve. And I wonder if this was happening in Canada as well as happening all over sort of the world, but particularly the United States, is that we're no longer making progress in improving cardiovascular disease mortality. We're no longer even stagnated. We're actually on a frank uptick in both men and women due to the epidemics of obesity and cardiometabolic diseases like diabetes. So this is absolute death rates, but if you look at absolute death numbers, but if you look at rates of change, actually the fastest growing heart disease death rate is in middle-aged women, which has increased 7% since 2017. This is an age range that I fall in. It's a busy time in a woman's life. They often have dependent children or aging parents, their spouses, their partners, their careers. There's, everything else that they're not, have to take the time to prioritize their own heart health, but it's so very important. Now, this is one of my other studies looking at death certificate data from the CDC for women under the age of 65. So in younger women, cancer is the leading cause of death. And we saw over this 30-year period that cancer mortality, fortunately, is going down in younger women at a rate of 1.3% per year in the US. But unfortunately, since 2010, heart disease mortality is not declining anymore, and it's on the rise at 0.5% per year. So the gap between cancer and heart disease is narrowing. And so if these trends are not overturned, heart disease is set to overtake cancer as a leading cause of death in younger women as well. And this is one of our papers that we published recently in the recent February Go Red for Women issue of JAHA, where we looked at myocardial infarction, specifically ST elevation myocardial infarction in younger women under the age of 65. And we saw for women under the age of 45, actually, STEMI is on the rise in the past 12 years. Now, if you look at absolute numbers, the numbers are still lower compared to other age ranges. But, this is an age range that often women and their clinicians, aren't thinking that heart disease is possible. I mean, many of unfortunately, heart attacks do happen in women under the age of 45, although it's not that frequent, but it's on the rise. And many women don't think they're at risk. But unfortunately, the cardiometabolic health of younger adults have been getting worse over time. And so we're seeing this more often. And it's just another plea that we need to optimize cardiovascular health throughout the whole lifespan, but more attention to young adults. Now, unfortunately, we're losing ground in the United States about awareness that heart disease is the leading cause of death of women. So the American Heart Association has sent out these surveys over the years and to female patients. And as in 2009, 65% of women cited that they knew that heart disease was the leading cause of death. And that declined to 44% in 2019. So we've actually lost ground in awareness, which is disheartening. More women cited cancer as their leading health threat. And this lack of awareness was particularly seen among Hispanic and Black women, and also among younger women, where arguably primordial prevention would be most effective if implemented earlier. So what we're doing right now is not working, and this is why we need to have new strategies for prevention, including community-based approach and getting all hands on deck, including involving faith-based organizations and other members of the community. So there, in addition to the traditional risk factors I think you're all familiar with, which there are some differences in traditional risk factors by sex as well. For example, diabetes and smoking are a greater relative risk in women than in men. But additionally, there are unique risk factors that women experience throughout their lifetime that men do not, related to things like menarche and PCOS, pregnancy, particularly adverse pregnancy outcomes, infertility, pregnancy loss, number parity, lack of breastfeeding, early onset menopause, and prolonged vasomotor symptoms that put a hallmark of women who's at higher cardiovascular risk. And hopefully the big take-home message, particularly to the clinicians in the audience, and I've been trying to get all my cardiology colleagues to do this, is the importance of taking a comprehensive reproductive history in all their female patients. Some of these risks, particularly the ones related to pregnancy, we see even several decades after the index pregnancy. And so we need to ask women about this history, because if we don't ask, we may miss identifying some of these risk factors that may not be captured by traditional risk factors alone. And so I directed our women's cardiovascular health clinic, and in our new patient form, we do, in addition to all the other risk factors, we do take a comprehensive reproductive history as part of their risk assessment. So we'll go over some of these things today. I'll start with cardiovascular risk factors in younger women, starting with the age of menarche. So if you look at a cohort of adult women that are now middle age from Norfolk, UK, we see that those that reported early onset menarche, the onset of menses at a younger age, ages 8 to 11, these women were more likely to be in poor cardiometabolic health later in life. They were more likely to have higher waist circumferences and BMI, more hypertension and dyslipidemia. But even after you adjust for risk factors, we actually see a U-shaped relationship with menarche, both early and late menarche being associated with increased coronary disease risk. So the early menarche, before the age of 11, that these girls have to have a certain amount of adiposity, body fat to have the onset of menses. And so it may be that there is the earlier onset, maybe some cardiometabolic imprinting that sets them up for later life cardiometabolic complications. Where the late onset menses, menarche after the age of 17 may hallmark an estrogen deficiency, such as primary hypothalamic amenorrhea, that also may indicate a sign that women may be at risk for cardiovascular disease due to loss of estrogen. So one thing I wanted to create more awareness around is the cardiovascular risk around PCOS, which is pretty common. It's the most common endocrine abnormality of women of reproductive age. 1 in 10% of 1 in 10 women, so 10% of women are affected by PCOS. And it's a complex genetic, hormonal, metabolic, and reproductive disorder. And it's the most common cause of infertility and subfertility, and most common cause of hirsutism. It's also the most common preceding cause of type 2 diabetes after you consider obesity and family history. And it's associated with a myriad of health effects, adverse health effects, such as anxiety, depression, obesity, endometrial cancer, fatty liver disease, and cardiovascular disease. Now, there's several different groups. Most people use the Rotterdam criteria, which is you need 2 out of the 3 for diagnosis. So you need evidence of anovulation as one of the criteria. So this is usually captured by irregular menstrual cycles. Either biochemical or clinical signs of hyperandrogenism, more male type hormones. So this is your Hirschism, your acne, hair loss, those kind of things. Or if you did get lab tests, clinical lab tests showing elevated androgens. And then cystic morphology of the ovaries. And note that these aren't true cysts. These are actually really just stunted follicles. But you only need 2 out of the 3. Which means that cysts on the ovary are neither sufficient or necessary for diagnosis. And actually, there's been a lot of push to try to change the name. The name really focuses on anatomy, these cysts, but it's really a metabolic disorder of hyperandrogenism that's really driving the risk. So there's been a lot of discussion and trying to change the name, but nobody can really agree on what the name would be, a metabolic disorder of women of reproductive age, or, but so anyway, the name is stuck. But there's different phenotypes depending on how many of these criteria, which ones you have, but the ones that are most associated with cardiovascular risk is the classical type, or type B, the hyperandrogenism and the ovulatory dysfunction. So the excess male-like hormones leads to an insulin-resistant state. Even in women with lean PCOS, the insulin resistance, these women are at 3-fold increased risk of developing type 2 diabetes. And there's a dyslipidemia pattern and elevated blood pressure and the hyperandrogenism. All this is associated with increased atherosclerosis compared to BMI matched control women and increase the risk of cardiovascular disease. This is one of our meta-analyses showing that women with PCOS had a 2-fold increased risk of having incident and prevalent coronary artery calcium, which is a marker of subclinical atherosclerosis. PCOS has also been linked with carotid plaque and with reduced brachial reactivity and other signs of early subclinical disease, even in these women who are fairly quite young. It has been linked with also future cardiovascular events, but the literature is a little heterogeneous depending on how PCOS is defined, and also how cardiovascular disease was defined. But overall, we see about a 30 to 50% excess risk after you adjust for risk factors for having a future cardiovascular event. But it does seem to be that excess risk does seem to be confined to the women of reproductive age. This is a Danish registry that followed women of PCOS for cardiovascular events. And we see here the dark line is the adjusted hazard ratios. So we see this excess hazard in women under the age of 50. But once a woman has survived over 50, free of cardiovascular events, and now is postmenopausal, having a prior history of PCOS doesn't seem to translate into excess risk later in life, probably because the relative hyperandrogenism and insulin resistance of being postmenopausal may overshadow the prior risk of having PCOS. Now, anovulatory irregular menses is one of the sort of classic features of PCOS. And just even asking about menstrual irregularity predicts both risk of diabetes and risk of incident CVD that we see from the Nurses' Health Study. 82,000 women who were young, aged 20 to 34, followed for 14 years for incident cardiovascular events. And they adjusted for a large number of factors. But we see women who had very irregular menses were 53% more likely to develop an incident cardiovascular disease. So essentially, a menstrual history is sort of a vital sign, actually, of cardiovascular health. Now, infertility has been associated with future cardiovascular disease risk as well as in this study from the Women's Health Initiative, a history of infertility is associated with increased risk of heart failure with preserved ejection fraction. And while some of this, may be explained by traditional risk factors or infertility factors like having anovulatory cycles, there does seem to be some excess risk still there. Now, I mentioned about the long-term risk of PCOS and how PCOS, though, is also associated with infertility. But even when women do become pregnant with PCOS, they're not out of the woods for cardiovascular complications in the short term. This is one of our analyses using the national inpatient sample, so a large registry that's representative of over 90% of U.S. hospitalizations for delivery. And we looked over this 17-year period, and both PCOS is on the rise and obesity is on the rise. Now, whether this is truly on the rise or whether it was diagnosed better, as years went on is a little bit not clear, but it does track with obesity. But we see that in adjusted analysis, even when we account for age and diabetes and other risk factors, women who had PCOS were, 56% more likely to have preeclampsia, and they're more likely to develop heart failure and cardiac arrhythmias and venous thromboembolism and peripartum cardiomyopathy. So even getting them pregnant, they're not out of the woods, and they need close follow-up and monitoring, for cardiovascular complications during pregnancy, delivery, and beyond. So how do we manage PCOS? These are patients who are not currently trying to get pregnant. So for all women with PCOS, you want to optimize, really focus on lifestyle because they're young, and really that's where we start with lifestyle changes, weight loss for helps mitigate some of the cardiometabolic risk, and screening them for risk factors. To address the hyperandrogen state, usually oral contraceptives are first line to address both the excess male hormones and the irregular cycles. If that is not sufficient enough, then you can add anti-androgens like spironolactone, or the other things like minoxidil for hair loss. But to address the weight and the insulin resistance, metformin's been classically used. I've really moved towards using GLP-1 receptor agonists. Again, this is if they're not trying to actively get pregnant. That's really helps with the weight loss and resolves or improves the insulin resistant state. And then if they're determined to be at elevated risk, using statin therapy appropriately. Challenges is many of these women are young, but if they're over 40, 45, I'll get a calcium score, as I talk about, to see if they have plaque, if there's some indecision about whether we just start a statin or not. And then there's a cardiovascular risk related to pregnancy. First of all, pregnancy loss is a risk factor for cardiovascular disease. So this is data from the Nurses' Health Study showing that women who had a loss of pregnancy, are at greater risk of cardiovascular disease, coronary disease, and stroke, about 21%. And this is something, many, physicians, cardiologists, and even in some primary care don't ask women patients about this. And often women don't bring it up, or they don't realize it's related to cardiovascular disease. And again, if we don't ask these questions, we may miss these women that may be at higher risk. And then there's risk related to total number of pregnancies, parity. So I work closely in the multi-ethic study of atherosclerosis MESA, and in MESA now, these adults are middle-aged to older age, but we asked them about their prior pregnancy histories. And women who had grand multiparity, more than 4 or 5 live births, were much more likely to be in worse cardiometabolic health later in life, with more cardiovascular risk factors. But even in adjusted analysis, parity has been associated sort of in a J-shaped relationship with excess cardiovascular disease. Now, this is challenging because actually there's been a couple studies that actually asked men about their parity, and parity turns out to be a risk factor in men too. So it's likely there is residual confounding by cultural and socioeconomic factors that drive larger families, but the risk is greater in women, suggesting biological effects as well. And it could be that women tend to gain weight with each pregnancy, and we know a very short interpregnancy interval, less than a year and a half between pregnancies is associated with increased cardiovascular complications during pregnancy, like preeclampsia or preterm delivery. Um, and also, so it may be that with each excess weight gain and multi-pregnancies, that there can be cardiometabolic dysregulation. So we previously showed in MESA that women with Grand multiparity had a worse adipokine profile, higher leptin, lower levels of adenectin. And we also showed, again, these women are older now, but women who had Grand multiparity were more likely to have excess of androgens, more of the male-like hormones, increased testosterone levels. That was maybe the mediating reason why they had adverse cardiovascular profile. So what about breastfeeding? Well, a lot of cohorts, especially this meta-analysis that had over 1 million Paris women, we see that women who reported breastfeeding, so all these different circles are the different cohorts, and the size of the circle represents how many women were in the cohort. So we see that breastfeeding for 12 months seems to be associated with decreased cardiovascular risk, coronary risk, and stroke. Beyond 12 months, there doesn't seem to be any incremental gain beyond that. Now, again, this is all observational data, right? So women who are able to breastfeed, who have the resources and support to breastfeed, are very different than women who are not able to breastfeed. And so there certainly can be some residual confounding. But there was a recent study also from the GORED from Women Issues showing that in women with a hypertensive disorder of pregnancy, that if they did breastfeed, that did seem to mitigate or reduce some of the risk of having later life cardiovascular complications. So gestational diabetes, we know is associated with increased obstetrical complications, large for gestational size infants, which lead to increased risk of C-sections. But as we also showed in this national inpatient sample over 15 years in the US, gestational diabetes is increasing, which kind of parallels with obesity. But it's also associated with maternal complications. There's a strong link, a twofold increased risk between GDM and preeclampsia. So those can go hand in hand. And women with GDM were also more likely to have stroke and peripartum cardiomyopathy, and so the cardiovascular complications as well. So it's more than just the sugar, but these women have 70% of them will develop type 2 diabetes within 5 years after delivery. So it's really important that even if their glucose normalizes after delivery, that they get close screening and follow up for incident diabetes. Now, GDM has also been associated with future cardiovascular risk as well. So we see a twofold increased risk of having a subsequent cardiovascular event. Now, some of this is because women with GDM are more likely to develop type 2 diabetes, and type 2 diabetes is associated with CVD. But even women who did not develop interim type 2 diabetes, having a prior history of GDM was associated with excess risk. And I don't have the slide in here, but in the Cardia study, we saw this as well, getting a calcium score 15 years or so after their index pregnancy. Women with GDM were about twofold more likely to have prevalent coronary calcium, a marker of atherosclerosis, even if they were euglycemic, did not have diabetes at that later visit. So just that prior history. And we showed something similar in this collaboration we did with McGee Pittsburgh. They had an interesting cohort of women who had adverse pregnancy outcomes and then came back 10 years later for cardiovascular testing. And this group already published their preeclampsia data, and they let us work on their GDM data. And we showed that women with a history of GDM compared to controls were much more likely to have a worse subclinical cardiovascular profile 10 years later. Again, these women are young. They're like 32, I think was the average age. So they're young, but they already had worse parameters of more diastolic dysfunction parameters. They had worse brachial reactivity and worse microvascular function by this glycocalyx test. So this is already this subclinical cardiovascular dysfunction like mediating why they're at excess cardiovascular risk and why prevention is so important. But preeclampsia is probably the biggest red flag. It affects 5 to 8% of pregnancies, and there's significant racial disparities. We know obesity and chronic hypertension are big risk factors for preeclampsia, and those risk factors disproportionately are more prevalent in Black women. But even when you account for those risk factors, there's still an excess risk of preeclampsia among Black women. And preeclampsia is associated, we'll talk about the long-term risk, but certainly, increased trouble at the time of delivery, which we see across all race ethnicities, peripartum cardiomyopathy, heart failure, pulmonary edema, all these bad cardiovascular outcomes. But since Black women are more likely to have preeclampsia, they have higher rate of these maternal morbidity complications, although we also saw some excess risk of our Native Alaskan Pacific Islander women as well. Now, there is significant disparities and biases affecting Black women, likely due to structural racism. When we looked at the impact of race and ethnicity with income, the intersection. And we showed that, among white women, having a higher income status was associated with more favorable outcomes in preeclampsia with lower risk of cardiovascular complications. But we did not see this among Black women of higher income. In fact, among women with preeclampsia, Black women who were of the highest socioeconomic status, meaning that they had health insurance, which is not guaranteed in the United States, they had higher income, they had all the advantages of having higher income, but they still had worse outcomes compared to the lowest income white women. They're more likely to have, stroke, acute coronary syndrome, and all these other complications, heart failure. So it's not access to health care. It's not lack of insurance. This leads to concerns that we're not listening to Black women when they're telling us something's wrong, and biases and structural racism in our healthcare system. So maternal mortality is on the rise in the United States. It's a really devastating trend in the wrong direction, and we need to do better for Black mothers. Now, but even if they survive their pregnancy in the first year, because a lot of these cardiovascular complications still can happen out to the first year, the risk still carries even decades later, even 20 years. I mean, there's even a study now looking 50 years out that show higher mortality. So this is why for the clinicians in the audience, even if you're seeing a woman who may not be of reproductive age, or there might be years out from their last pregnancy, we still need to ask about their pregnancy history as a window both to their past and future cardiovascular health. So we see that having a history of preeclampsia is associated with a twofold increased risk of having a future coronary event and about a fourfold increased risk of heart failure. And there was a wonderful study just recently that your group led, Dr. Tyus Catino looked at vascular function of women with history of preeclampsia, and showing that preeclampsia sort of adds 6 years of aging, vascular aging. And if some woman had severe preeclampsia, that's 11 years of vascular aging. So it's trying to prevent preeclampsia is so critical, and we can talk about that. But I really liked this slide that has the adverse pregnancy outcomes and the cardiovascular outcomes and shows all of the excess risk. So what's the chicken versus the egg? What came first? Well, we do know that being in poor cardiovascular health prior to pregnancy does increase the risk of having an adverse pregnancy outcome. And that's why it's so important that we optimize the cardiovascular health of our youth, our girls, and our young female adults before entering pregnancy. But even because, if they have subclinical cardiometabolic disease and then they become pregnant, as nature's free stress test, this becomes manifest in those APOs. But there's also thought that these adverse pregnancy outcomes increase cardiovascular risk in a causal fashion. So in the setting of preeclampsia, this is due to adverse remodeling of the spiral arteries. So essentially the placenta is ischemic, and that sets off all of this hormones, this increase in SFLT, this tyrosine kinase, and reduction of placenta growth factor, inflammation increase, sensitivity to angiotensin II. And so this adverse hormonal milieu can further propagate and damage, cause endothelial damage that sets these women up for later life cardiovascular complications. So it's not just a marker of being less healthy prior to pregnancy, it's likely causal too. And that's why we really need to focus on a life course event about optimizing cardiovascular health throughout the lifespan, before pregnancy, during pregnancy, the interpregnancy interval to avoid sort of weight gain between pregnancies and long term. Because we know that a mother's cardiovascular health status is associated with her offspring's cardiovascular health status at 10 years. And so supporting women throughout this cycle is critical to optimize not only her own cardiovascular health, but her offspring as well. And so it's really important to have this multidisciplinary cardiobstetrics model to optimize the cardiovascular health of women from preconception to pregnancy to labor and delivery to the postpartum period to the fourth trimester out to the first year and then long term. And then there's risks related to the menopause transition, particularly when it comes early and the influence of hormone therapy. So there are a lot of metabolic changes that happen at menopause. Even if the weight itself doesn't change, there's a change in body composition with more deposition of adipose in the visceral cavity at menopause. Some women nickname this the menopausal middle, and women hate this. They become more male-like pattern and deposit more weight in the abdomen, which is associated with insulin resistance and this worse dyslipidemia pattern with increase of LDL at menopause, increased triglycerides, and reduction in HDL with loss of estrogen, with increased risk of blood pressure and endothelial dysfunction. Now, many women don't really talk about vasomotor symptoms, but vasomotor symptoms is affected of 75% of women who transition through menopause, but only 25% seek help for it. So many women suffer in silence with this. But it's not just benign. Data from the SWAN study that followed women around the menopausal transition for up to 20 years after that showed that women who had a history of very frequent vasomotor symptoms, having more than 6 episodes in a 2-week period, or very persistent vasomotor symptoms. So if they are exceeding beyond 5 years, if they're lasting a very long time, that was a marker of excess cardiovascular risk. And that's why we need to ask about that. Going through menopause early, so if one goes through menopause before age 45, we call that early. Before 40, we call that premature. But it's really almost linear looking at menopause age below this threshold. So the average age of natural menopause is about 51. So anything really below that, particularly the earlier, the greater the risk in adjusted analyses. Now, where men have this gradual andropause, there's loss of testosterone about 1 to 2% a year over decades. But women have this abrupt hormone change at the final menstrual period with this sudden loss of estradiol, a life change that men do not go through. And some of my work in MESA has been focused on looking at hormone levels in women after menopause. And we showed even in adjusted analysis that women who had more androgens, who had a more male-like pattern, had increased cardiovascular risk. So we kind of see this, and we looked at this, a bunch of subclinical phenotypes as well, and showed that higher testosterone levels were bad in women. So we see this over and over again from the PCOS women who had higher androgens, and also in women who had grand multiparity, and also post-menopause, that the more hormone pattern that's closer to a male-like pattern in women was associated with excess risk. But the question is what to do about this. So, the landmark study, of course, was the Women's Health Initiative that showed that oral conjugated equine estrogen plus progestin, did not lower cardiovascular risk in postmenopausal women, but actually was associated with trend for excess risk. But the study had a number of really important limitations that are, first of all, the biggest one is that the average age of women was 63 in this study. So many women, half the women were quite far from the menopause transition. And many of the women weren't even having vasomotor symptoms. It was being used, for prevention. So many women were much older, and we didn't really see this excess risk if you looked at the subgroup that was closer to the menopause transition. So unfortunately, after this, hormone therapy prescriptions dramatically plummeted, and people have shifted to not using hormone therapy at all. And the pendulum might have switched too far in the other direction, because there are some women who really are suffering from vasomotor symptoms that would benefit from hormone therapy. But we're still not recommending it for the sole purpose of cardiovascular disease prevention. We have a lot of other things we can do for prevention, statins, things like that. But for women who have symptomatic vasomotor symptoms, if they're under 60 or within 10 years of menopause, there's still an indication for them to help support their vasomotor symptoms. Also, for women who go through early menopause, if they don't have any contraindications, menopausal hormone therapy is recommended until they get to the average age of natural menopause. But generally, we don't initiate, and we try to wean off if women are now more than 10 years from menopause or over age 65, because that's where some of the excess risk we see with stroke is in this age range. And we still are avoiding oral estrogens in the higher risk women who have cardiovascular disease or history of VTE or high triglycerides or prior breast or endometrial cancer. And so this is why we need to do a cardiovascular risk assessment prior to initiating menopausal hormone therapy. So we talked about the people who are contraindicated that have those risk factors for systemic hormone therapy. But the women who are low risk may get the green light. And then there's this whole group in the middle who may have, one or more risk factors where it's part of a patient clinician risk discussion. And in this group, often I get a coronary calcium score if I'm not sure about their cardiovascular risk. And note that this is really for systemic hormone therapy. There's really no contraindication for topical vaginal estrogens to treat the genital urinary symptoms of menopause, because that doesn't really have systemic absorption. And some studies have suggested that transdermal estrogens may be less risky than the oral estrogens because they don't have the first pass effect through the liver. But we really don't have a large outcome study for that, but that is some consideration. So I work closely. We have a menopause program at Hopkins called the Women's Wellness and Healthy Aging Program, and it's really great. We have a patient navigator that takes an intake. I don't know about your health system, but a lot of health systems in the U.S. are very complicated to navigate. So normally a patient would have to call like multiple different departments and make multiple appointments with multiple specialties, and it can be overwhelming to find the right people in all these disciplines. So they do one intake with our coordinator, and the coordinator knows all of our admins and then helps schedule the patient for all of the clinicians that are interested in women's cardiovascular health. So there's someone who does bone disorders for women who are at risk for osteopenia, osteoporosis. If they have cardiovascular risk, they come see me. So, there's a psychiatrist, there's a GI doctor. And so it makes it all easier for patients to navigate, and we all work closely together. So I think love these interdisciplinary programs for women's health. So how do you then take this, you've asked your patients about this history, how do you incorporate these risk factors into risk assessment? Well, I was pleased to be part of the 2019 ACC/AHA primary prevention guidelines, and they listed a number of risk enhancers. These are things that are, not in the pooled cohort equations, but are associated with excess risk, and the presence of these would put a woman or a man in a higher risk category that would favor the initiation of statins. And so I was really pleased that they included these female-specific factors as risk enhancers, having premature menopause or an adverse pregnancy outcome like preeclampsia, as well as inflammatory conditions like rheumatoid arthritis and lupus that are more common in women. So we did still say in our US guidelines to start with a 10-year risk assessment for patients 40 to 75. And we know that this risk score is not perfect. This is just a starting point where high-risk individuals, more than 20% 10-year risk, would benefit from lifestyle changes and drug therapy, statins to reduce LDL by 50% or more. But low-risk individuals' lifestyle may be enough, but there's this big group in the middle, those that are borderline or intermediate estimated risk. And this is where you would do a clinician risk assessment. You would see if you have those risk-enhancing factors. But our guidelines acknowledge that sometimes that even after you assess risk, there can be still some uncertainty about the risk or the net benefit of preventive therapy, such as statins. A lot of patients are statin reluctant. And so when there is some indecision about their risk, we gave a 2A indication to consider a coronary calcium score to help revise their risk and guide shared decision-making about preventive interventions. And so you may be familiar with this test. It's done by non-contrast CT. As plaque is building up in the arteries over decades, a certain percentage of it can become calcified, and calcium can show up bright on X-ray. So for the low dose low radiation protocol, about the same as a mammogram, you can see this calcium. And in the MESA study, coronary calcium really emerged as the superior prognostic marker of risk of who went on to develop a cardiovascular event. So it predicted risk better than age, better than LDL cholesterol, better than risk scores, better than all these other things like IMT or ABI or CRP, likely because it's actually measuring the disease itself. It's like a marker of atherosclerosis, and instead of predicting disease, is actually measuring disease. And so it's really integrating a lifetime of exposure between genetics and traditional novel risk factors, and the presence of absence can upgrade or downgrade risk. And again, this is more useful in older adults. It's meant to be applied age 40 to 75 who are asymptomatic for risk assessment. But we see here in the MESA study focusing on women, so this event rate, so the dotted line is the 7.5% 10-year threshold. This is the threshold that we think is a net benefit for statins or primary prevention. Women with a 0 calcium score have a very low risk of events over the next 10 years, as do men. Now note that this is not no risk. A 0 score is not no risk. There's still events here, but it's a low enough event rate that patients and their clinicians may decide to defer statin therapy if that's their desire. Although I have lots of patients I still treat with statins, even with a 0 score, because they're younger and have a high lifetime risk. But the presence of any calcium associated with the future risk of event in a graded fashion. With the higher the score, the higher the event rate. And all of these, any non-zero score did cross over this threshold in 10 years. And so our guidelines recommend statin therapy if the calcium score is above 100 or above the 75th percentile. But it should be considered, and this is how I practice, really any non-zero score, because that means that there is atherosclerosis there. Now, at a given age, women are less likely to have a prevalent coronary calcium score compared to men, but the presence of a coronary calcium score when it's there, confers a greater risk of women than in men. So we see in the Coronary Calcium Consortium that looks at 20 years of cardiovascular mortality, that both men and women with a 0 score had a very favorable prognosis. So for reference, this is 1% CVD mortality, so a very low rate for men and women. But when coronary calcium is present, any non-zero score conferred a 26% greater risk in women. And we see this for calcium scores above 100 or above 400 or about 2 vessels or 3 vessels involved. With any burden of atherosclerosis, it carries a worse prognosis in women. Now, while calcium scores are meant to be applied in asymptomatic individuals for risk stratification, women are actually more likely to have angina compared to men. But in the setting of angina, in the setting of symptoms suggestive of ischemic heart disease, across all age groups, women are more likely to have non-obstructive disease in the setting of angina. And so there's been much more awareness and attention to this phenotype, myocardial infarction with non-obstructive coronary disease. MINOCA is the unstable form, when someone's had a heart attack. And then in the stable patients with angina, either ischemia with non-obstructive coronary arteries or angina with non-obstructive coronary arteries. And I'm glad this is getting a lot more attention. Historically, women would have symptoms of angina. They would have a stress test, and the stress test might even be positive. And then they went to cath and they didn't see any obstructive disease. And they told the woman, oh, it was a false positive stress test. You're fine. You're just anxious. Do more yoga. And, they didn't get a diagnosis. They didn't get treatment. And as I'll show you, this is not benign, and we did a disservice for these women all these years by not giving them a diagnosis. Because the epicardial arteries that we're looking at on angiography is only 10% of the coronary circulation. The rest of it is all microvascular, or the prearterioles, arterioles, and capillaries. It's all below the surface. And this is what makes up most of the resistive circuit of the heart. And so when the heart has metabolic needs like exercise or stress, there should be the ability to increase your coronary flow reserve, be able to dilate by, more than twofold. And so the inability to dilate, the inability to augment the blood flow to match the working needs of the metabolism of the heart is coronary microvascular dysfunction. And it's not benign. That we see that in people with ischemia, once you rule out obstructive disease, this is data from the WISE, the Women Ischemic Syndrome Evaluation, that the inability to dilate, the coronary flow reserve less than 2 is associated with adverse cardiovascular outcomes. There's also another phenotype where people can get epicardial vasospasm of the coronary arteries, vasospastic angina that's associated with events. And again, you can't visualize the microcirculation on imaging. So it's really doing tests to assess the function of the microvasculature. But the important thing is when there is ischemia to note that stenosis only is one etiology. And remember that ANOCA and vasospasm are also contributors of myocardial ischemia. So it's not just about stenosis. And my big plea for, when taking care, I see a lot of patients in my microvascular angina clinic that if someone has symptoms, these are symptomatic individuals. Once you rule out obstructive disease, either by cath or a coronary or CT, you're not done yet because they're having symptoms and you haven't given them a diagnosis yet. So just saying there's no obstruction, you're only one step through the process. Because having ANOCA is not benign, that we see that women who have ischemic symptoms, who had either no obstructive disease here in the yellow or mild disease in the pink, they still had higher 5-year event rate compared to asymptomatic women. And furthermore, I really like this comparison that Dr. Reynolds did from individuals who were screened for enrollment in the ischemia trial. So the ischemia trial was patients who had to have evidence of ischemia on a non-invasive test, moderate severe ischemia. And then they had a CTA to see if they had obstructive disease. If they had obstructive disease, they got enrolled in the ischemia trial. If they had non-obstructive disease, they got enrolled in this registry called the CHOW registry. So not surprisingly, the registry of people who had ischemia on a stress test but no obstructive disease were predominantly women, and the people in the trial that had obstructive disease were predominantly men. But after that, if you were to do a comparison, they look pretty similar. And if you look at the number of ischemic segments on their index stress test, or how frequent their angina is, or how their angina affects the quality of life, if this wasn't labeled, you'd have trouble figuring out who were the obstructive people and who were the non-obstructive people. The point is that there's still poor quality of life, even without obstruction. So it's not benign. So I was really pleased that the more recent AHA and ACC US guidelines for chest pain does incorporate this whole algorithm of how you approach when you suspect ANOCA, ischemia with non-obstructive coronary disease. So there is an invasive approach, but not all places do the invasive coronary functional testing. I don't know if you do it here. We actually don't even do it at Hopkins yet for issues related to equipment, so I have to send out. But this is where they're in the cath lab. They have an angiography and FFR to rule out obstructive disease. Then once you rule out obstructive disease, they have a flow wire down and you give adenosine, a non-endothelial independent vasodilator, and measure coronary flow reserve. So coronary flow reserve less than 2 means that there's CMD there. And then the second step is that you can, they would give acetylcholine, which is endothelial dependent, and see if there is vasospasm, if there's more than 90% narrowing. And so patients can have CMD alone, they can have vasospastic angina alone, they have a combination, or if those are both normal, then it's not cardiac. Now, if you do the non-invasive approach, there's a 2A indication. So you can either do a stress PET or stress CMR, as long as you're measuring the myocardial blood flow reserve. So in my institution, we use a lot of stress PET because you can evaluate for ischemia, and also the myocardial blood flow reserve, the coronary flow reserve, because you can have ischemia without CMD, you can have CMD without ischemia, or you can have both. The big challenge here is that this doesn't get at the vasospastic phenotype. It's only looking at sort of the coronary flow reserve or coronary microvascular dysfunction, but doesn't look for the vasospastic angina. So that often you can figure that out by a good history. But the management, you want to assess history of risk factors. Cardiac rehab is good for this group of angina, just like it is for patients with obstructive disease. I put all patients on statins and ACE or A or Bs. In the Y study, there was improvement in angina with an ACE inhibitor. And then depending on the phenotype, you can do tailored therapy. So if they have the vasospastic angina type, I avoid beta blockers and use high dose calcium channel blockers and nitrates. If they have more of the angina CMD phenotype, then you have a little bit more options, including calcium channel blockers and nitrates, but also ranolazine, and you can use beta blockers in this group. But in the CORE-MICA trial, where they did they compared invasive coronary functional testing, which is angiography alone, doing the testing and coming up with the diagnosis and then tailoring the therapy, they were able to show that tailored therapy did improve angina and quality of life. And there was some people in the study that actually everything was normal and they didn't actually have a NOCA after all, and then so they don't need all these medicines. But this was only at 151 people, so it was too small to look for events, but you did show improved quality of life. And then even in obstructive disease, patients can have CMD. So just be thinking about CMD and other disease etiologies. Many patients after having a stent or bypass have residual angina and they go back to the cath lab and everything's patent, but they still have disease. And we might see this with other etiologies like Takotsubo or stress cardiomyopathy or HFpEF as well. And I'll sort of end just with one of this other studies about the importance for listening for women. We looked at patient-reported outcomes and patients with cardiovascular disease and showed that this was, again, highest risk patients with CVD, and we looked for adjusted for all kinds of risk factors, comorbidities, other cardiovascular risk factors. And female patients were 25% more likely to report that they actually had poor communication with their healthcare provider. And they were 23% more likely to report that their doctor didn't listen to them, and they felt that their doctor didn't spend enough time with them or didn't respect them, and they had poor patient satisfaction. So they weren't having as good an interaction with the healthcare system. Now, when we first submitted this paper, we had a reviewer, I think it was reviewer 2, saying, well, this is subjective. Maybe women just whine more. Maybe they just have greater expectations of what a doctor visit should be like. So then we went back and looked at hard outcomes. This is linked to pharmacy data. And these were all ASCVD patients who had class 1 indication for statins and aspirin. And we showed that women were less likely by 45% to be treated with statins and aspirin and more likely to be utilizing the emergency room. In other words, women were being suboptimally treated and they felt that way too. And so I want to have time for questions, so I'm going to skip some of the last few slides, but the importance that we show across disease studies that women are under-enrolled in cardiovascular clinical trials, which is a problem because cardiovascular clinical trials is where we generate the evidence for our guidelines. And if there's not women in the trials or other diverse populations, then the trial results may not represent the patients we care for every day. And we did show some correlation between women as study investigators with increased enrollment of women in trials. And that's one of the things our Impact Center is trying to focus on, is improving diversity in clinical trials. So to summarize my last slide, cardiovascular disease is the leading cause of death in women worldwide, and that men and women do share many risk factors in common, but there's these unique risk factors that I went over today, and why it's so important to assess a reproductive history, that atherosclerotic plaque is prognostic in women, and women can still be having coronary microvascular dysfunction even if no obstructive lesions found. And women are underrepresented in trials, and there still remains a lot of opportunity there to improve that. So thank you. I'd love to take your questions.
Thank you so much. That was really wonderful. For the live audience, I know we only have a few minutes, but for the live audience, if you have any questions, please make your way to the mic across the room there, to the standing microphone. Please introduce yourself very briefly before you state your question. And reminder to the virtual audience here, I think you had more than 60 people online, so quite the audience. Please use the Q&A feature. So I've been told that there's something in the Q&A. See if we can find that. somebody can read the QA, that would be
Check the chat.
chat. Yeah. Okay.
Okay.
Show. There we go. There we go. Thank you.
Okay.
Okay. No Q&A box. Okay. Perfect.
Okay.
So I'll just read it if you.
Oh, sure.
So Dr. Gattino says, thank you, Dr. Michos, for this comprehensive overview, and welcome to Ottawa. So she couldn't make it, but let's see. So do you think the increase in STEMI seen in younger women is due to atherosclerotic disease or increased index of suspicion and diagnosis of SCAT? So
Yeah. So it's a good question. I mean, I'm glad there's more recognition of SCAD. I think SCAD's been happening for a long time and it was just not recognized. And I didn't get to talk about SCAD today, but I do care a lot of SCAD patients. And at least in my analysis with STEMI, we did try to adjust and account for dissection. And so unfortunately, the national inpatient sample, there's just one code for coronary dissection. So it doesn't count for it spontaneous or iatrogenic, but it didn't seem to be driven by dissection. So I really think the biggest driver is the fact that cardiometabolic health of younger adults is getting worse. Like we're seeing obesity at a younger age, we're seeing hypertension at a younger age, the whole cardiometabolic health is shifting. And so that I think is driving, we have onset of type 2 diabetes and adolescence. So, I think that's driving the largest driver. However, we are seeing more SCAD, whether that SCAD is actually increasing in prevalence because of stress or other factors, or whether we're just doing better in diagnosing is not quite clear, but SCAD is also going up, but I think that's probably due to better diagnosis. And then I'll take a question in the room. Okay, there was, I guess there was a couple questions. And the second one is, the female specific factors so important for the far majority of women calculus low risk, no matter how you slice, even with the risk enhancers. Yeah, so this is challenging because, so I really think about a lifetime risk. When you look at 10-year risk, women inevitably, are very low 10-year risk. And then, the risk enhancer factors may put them in a higher risk category. But, what is the appropriate age? Do you start looking for subclinical disease? Calcium scores are not really useful in 20 or 30-year-olds, if they have any kind of plaque, it hasn't calcified yet. Sometimes when I'm worried, and the patient's a little reluctant to start a statin, I might look for carotid plaque, not IMT, but carotid plaque, but looking some markers of atherosclerosis. But I mean, statins are effective and safe, and I recommend just treating earlier, especially women with dyslipidemia. FH is seen in 1 in 250 individuals, but women are undertreated because of the concerns of, not of getting pregnant while on the statins. But statins are likely not teratogenic. In fact, there's studies ongoing now, which I think will be interesting, whether statins can prevent preeclampsia. We generally do stop statins before a woman starts pregnancy when they're trying to conceive. But if they accidentally become pregnant on a statin, we just stop it, when pregnancy is identified. But the FDA has removed its higher risk, highest warning label. So that gives us more flexibility, like in our highest risk women, that we can use them. So I think we wait too long to treat. And there's a lot, we think about cholesterol years, even moderately elevated cholesterol for sufficient years can increase, earlier onset ASCVD. And so really need to be thinking about shifting risk factors lower in life and not waiting so long to treat. So sometimes, the argument of waiting till you have an elevated calcium score, like they already have disease then. And sometimes I think we miss the boat about treating earlier in life.
How's that? Thanks very much. Welcome to Ottawa. Great presentation, super comprehensive. I have two questions. So your statin question just made me think how much there's reluctance, obviously, from providers to treat early. It sounds like you're doing that. But how much reluctance are you still seeing from patients, from female patients? And how are you sort of addressing that when your patient is reluctant to start the statin at an earlier age? And then I have a second follow-up question.
Yeah. So if somebody is, over age 40, I do get a lot of coronary calcium scores just because seeing is believing. So there's a lot of people, these abstract things, I'm at 10%, 10-year risk. People don't know what that means. They think, oh, I'm a 90% not having risk. So, but seeing is really believing. If you actually get an imaging and I pull up the CT scans and show them their pictures, patients are much more likely to go on lipid lowering therapy when they see their own arteries and see disease in their own arteries. And there's been studies like that from Eisner and even the Vanguard trial study from the CoreCal study coming out in Intermountain Health, showing that you can, in the CoreCal study, Vanguard, they're comparing calcium score assessment for screening versus risk factors alone, and showed that the calcium score approach, that people were more likely to initiate treatment with statins and get their LDL a goal at 1 year. So it just shows that seeing is more believing. People are more likely to start preventive therapy, when they actually see that they have disease. Now, women are more likely to report statin-associated muscle symptoms, and that's been seen over and over again. And certainly I talk to patients about the nocebo effect, but if they're in that high-risk category, so if they're a very high risk, particularly if they have FH, LDL is above 190 milligrams per deciliter, we have a lot more options. The important thing is getting the LDL to goal. So it's not really anything magical about statins per se. It's all about the LDL, because now we have a number of trials of non-statin therapy, and we see pretty consistently that for a given LDL reduction, for every 1 millimole per liter, which is about 39 milligrams per deciliter, we can reduce, MACE by 20%. And so important thing is just getting them on some treatment. So while I try to do a statin re-challenge and go through all that, if medicines don't work and patients that won't take them. And so if they absolutely won't take them, then I kind of move on now to these other non-statins, ezetimibe, bempedoic acid, or if they're really high risk, PCSK9 inhibitors or inclisiran is an important thing to treat. But in terms of younger women, the concern about pregnancy, I think, we have some more reassurance about statins. Generally, most women will stop statins during conception, pregnancy, and breastfeeding, except if they're at very high risk. If they've had a recent acute coronary syndrome, it allows for more flexible options. So there's a trial ongoing right now. In animal models, statins seem to prevent preeclampsia, which is really interesting. They improve endothelial function, reduce inflammation, they lower SFLT. And so there's a trial ongoing now, enrolling women at high risk for preeclampsia who've had prior preeclampsia at 12 weeks of gestation, pravastatin versus placebo. So right after the first trimester at 12 weeks. So that trial's ongoing, and they're seeing whether the statins can prevent preeclampsia and adverse maternal outcomes. So I'm hopeful, but even if it doesn't show it prevents preeclampsia, if we can even show that it doesn't cause harm giving statins to pregnant women, that will open up some more options, especially for our highest risk women, such as those that have FH.
Thank you. And my other questions are, I loved your clinical tool, taking the pregnancy history and of course the sex specific risk factor history. How much of that is in your outpatient clinic? How much is it, being used kind of standardized across all cardiologists or on the inpatient side? And what's your electronic record? Out of curiosity, of course.
Yeah, so I use Epic. My form is not disseminated throughout all of Epic, unfortunately, but so I have implemented in our own cardiovascular clinic as this is all outpatient, new patient form. Although I am definitely hoping people will ask as an inpatient as well. It's interestingly, I was talking to some other groups though at Kaiser Permanente or other places. They're actually hoping to pilot actually having it in their EMR as sort of a standard entry field. So I think that can be built in. It just needs to be the buy-in that people need to do it. And then once it's in there, people need to know what to do with that information. And that it could be some flags. And so people have to know, like, if we collect this information, what to do about it. So there's that education piece. So it's not in our EMR other than what I put into our new patient form and then through REDCap, but I would love to have it in our EMR.
Question from Dr. Redpath on the,
Okay.
I don't know if it's still there.
Statin tolerance. Yes.
Maybe not. I thought I saw his name up there. No. While you're looking for it.
Yeah, so I mean, some of the questions, I guess, with observational studies, I mean, the problem is that, with randomized clinical trials, unfortunately, we can't do for every single, patient outcome and things like that. And the challenge with doing these trials in these younger women is that, this does have relative risk, but often the risk is not for decades later. And so to do a trial, and file somebody for 20, 30, 40 years is this really challenging. And so that's the approach of what do you do for women that are 20s and 30s and 40s, and when do you start pharmacological therapy, such as statins, versus if they don't, meet the criteria by their 10-year risk score. And so, looking at a lifetime approach risk is good, but unfortunately, it's challenges of randomized clinical trials in women with low event rate. So then it comes up like, is there any surrogate outcomes that would be acceptable if we can't follow people for events for all these decades in clinical trials? Is there any kind of surrogate outcome that would be acceptable outcome, and that still people debate that.
Yeah, great rounds. Thanks for the comprehensive talk. And I see Mike's ready for the trainee, so I won't take very much time. I did have a quick question, and I saw in the presentation you talked about the risk of preeclampsia related to race. And then I just wonder if that's, I think you started to address that, but is it really about race and more about socioeconomic
Right.
factors and so on? And should we be thinking of it in a different construct?
Oh, no, I think it's the latter. I think I tried to get at the intersection about when I looked at the intersection with social economic status. So race is really a social factor, that so that this is not, these differences are not due to really genetics, but due to social factors. And some of this is higher prevalence of chronic cardiometabolic diseases like obesity and hypertension pre-pregnancy, which is also related to these social determinants of health. But in that one study, we showed that even Black women of the highest socioeconomic status, that they had insurance, they were the highest income, they still had worse outcome compared to the lower income white women. And so I really think that this is due to bias and structural racism, and then we're not treating Black women the same as we are white women. So I definitely think it's all the latter, not only the social determinants, but even people of high income has to do with biases of how the healthcare system is treating patients differently, not recognizing or addressing people's concerns in the same way. And that's certainly a much more complicated and harder thing to address. But I definitely think race is a social factor and not, it's really a poor proxy. People are more alike than different is really poor proxy for genetic differences.
Okay, thanks so much. So give her a round of applause. Thank you so much. That was wonderful. So we'll hand it off. But if anyone has any outstanding questions, I saw some here, 9:30 to 10:30, we're having a Women's Heart Health Roundtable. So bring those questions, and so we'll see you then.